what we all need to do if we're technology providers, like Babylon or, push doctors or aiders of this world. I think every technology provider will need to be publishing peer-reviewed journals and articles, because we're going to be compared to drugs at the end of the day.
So EGP learners, that was Dr. Sandeep Bansal of Medic Creations and the product Medic Bleep, as we talk about safety use of technology in healthcare. And what follows is a really interesting discussion between Sandeep and I about this aspect of safe use of technology in healthcare, particularly using Medic Bleep as an example, but also how this can be applicable and useful to you in primary care. Really recommend you have a listen to this podcast. I'm going to make you laugh, it's going to make you smile, and it is going to be useful for you if you're thinking about creating a new primary care network as well. Make sure, as always, you subscribe to our podcast on Spotify, iTunes, or Android. And as always, if you've got any questions, feel free to contact me directly at EGP Learning or at Dr. Gandalf52. Shall we begin? So, listeners, I'm joined by Dr. Sandeep Bansal. Are you there, Sandeep?
Hi, Sen. Yes.
How are we doing today?
I'm good, thank you. How are you?
Yeah, not bad. Busy morning as ever. How's things for you?
Yeah, good, thank you. Got a conference that I'm attending today, so it should be fun.
Should be interesting. So thank you for joining us. I know our listeners are keen to hear about some of the stuff that I know that you've been involved with. And I guess the best way to introduce that is, I guess, for you to introduce yourself properly to all of our listeners. So tell us about you.
Yeah. Well, firstly, thank you for having me, and hello to all the listeners. I'm a GP trainee by background, but I've gone into the health tech space in the last 4 years. I'm the founder and CEO of Medic Creations, and our first product is Medic Bleep, which you may or may not have heard of, with the whole page ban stuff that's been going around about 4 weeks back with Matt Hancock's announcement. But a deeper dive into my background. So I'm born and brought up in the UK, but I decided to take a gap year between A-levels and med school to help my parents run their first nursing home.
Okay.
And then I decided to explore and look at how other healthcare systems work. So I actually decided to go to India to do my medical training.
Okay.
I went to a university called Manipal down in the south in Karnataka. That was an interesting experience. And then I did a year of internship in a government hospital in Delhi. And that was eye-opening. I was in charge of a 40-patient ward usually, and in those 40 beds, I typically find 80 to 120 patients at any given point in time.
Wow.
Especially during dengue season and chikungunya, and when you've got swine flu going around, and that made me appreciate the NHS a whole lot more, I think.
So kind of like a Saturday night in A&E basically, but every day.
Yeah, it was crazy. Typically in the NHS, when I came across as an F1, F2 in Wales, I'd have maybe 20, 25 patients on my list. If I was really unfortunate. But there, I had 80 to 100 patients on my list, right? At all times. So it gave me a new appreciation for the NHS for sure. Okay. I then came back across to the UK, F1, F2 in Wales, took another gap year to do a master's in paediatrics at Imperial, which was good fun. But also, again, operationally run nursing homes with my family. And by this point, we'd scaled the business to about 600 beds. Okay. So grown it from 30 beds in 2004 to 600 beds in 2012. And then I went into GP training because I wanted to do portfolio work, I thought. And GP was the best way that I could see having a career in medicine and also doing other things, dabbling in business or technology, and doing other things. I thought GP was a great route for that. But 2 years into GP training, I kind of decided to go the health tech route and just go all in.
Okay.
And that was 2014, December.
Okay. So what's happened since 2014 then?
Gosh, it's been a really painful journey. It seems like many, many years, more than the 4 years that have gone by.
Mm-hmm.
But initially started to create the product, got my own team out in India, a development team. That took some time to build up. Then started creating the product, Medic Bleep version 1.0, and went the B2C route. So started giving it to clinicians to use.
Mm-hmm.
But that model just doesn't work for many reasons. So, for example, I had data sharing agreements in place with a few trusts and a couple of CCGs. But then I started getting downloads from many, many other trusts
Mm-hmm.
and other CCGs, and I didn't have the right documentation in place with them or the clinical safety documents. So realized that doesn't work, and I had to shut that model down.
Mm-hmm.
And so I did. But also, it didn't work because, if you have 10 clinicians using it in one hospital, but the rest of the team not,
Mm-hmm.
then you're not really adding true transformative value to the system.
Mm-hmm.
And my passion was, well, actually, how do we move the health and social care system into the 21st century and truly help enable the transformation around the processes
Mm-hmm.
that this sort of technology could enable the workforce to utilize.
Okay.
And so I shut that model down, and this is January 2017.
Mm-hmm.
And I started to look at technology very much like a pharmaceutical, Hassan.
Mm-hmm.
So what I mean by that is, what does a pharmaceutical company need to do to get a drug into the system, approved by NICE, and we as clinicians can prescribe it, right?
Yep.
And so, of course, what they've got to do is their phase 1, phase 2, phase 3, phase 4 clinical trials. And I started to look at technology very much in that way. And I thought, well, if they need to do that, then why do we as technology providers not need to do the same thing?
Mm-hmm.
And so I embarked on a phase 3, essentially, clinical trial. I reached out to 5 GDE sites. So if your listeners don't know what that is, it's Global Digital Exemplar. So one of the top 10 or 12 trusts in the country digitally. Reached out to them, and 20 minutes after my email had gone out to the chief exec of West Suffolk, the medical director of that organisation had downloaded Medic Bleep and called me through it, which was interesting. Yeah. So he's very keen to make it happen,
Mm-hmm.
And you need that. You need someone equally as passionate on the organisation side to drive it. And I was very fortunate to have found that person. And so we embarked on a pilot, and we did a 4-month trial, 250 staff involved, including community staff, and so community midwives, basically, and also hospital teams. And we did a time and motion analysis, and we showed in that every single nurse saves 21 minutes per shift every single day, basically, every single shift. And a junior doctor can save 48 minutes every single shift, every single day. And that peer review has now got published a couple of months back, I think, in a peer review journal. And I think that's what we all need to do if we're technology providers, like Babylon or, push doctors or aiders of this world. I think every technology provider will need to be publishing peer-reviewed journals and articles, because we're going to be compared to drugs at the end of the day.
Sure. And it's interesting you take that analogy. I guess listening to what you've just said, there's a couple of things that I picked up from that. So one, very much that you're safety conscious. So you had a model, you realized it wasn't working from a safety perspective. So you realized you had to change that model to protect that element of things. And then the second thing is this analogy you mentioned between tech and medications, because I think that's an easy one for people to understand. And it's interesting, that's the same analogy that we heard from Liz Ashell-Payne, who's CEO of Orca, the organisation for a review of care and health applications. And she made the exact same analogy that, you know, how you think about tech, how you get clinicians to use it, how you get patients to use it, is if you think about it the same as how we use medications, it's the same thing. And the safety and everything that comes with it has to be the same level. And with obviously drugs, we have evidence base to tell us how to use them. So we need evidence base, like you said, peer review journals to show people how to use the technology, which is, you know, really encouraging to hear.
Yeah, absolutely. So I think, you know, as clinicians who are getting involved in tech,
mm-hmm.
surely we have an upper hand on understanding that, right? Because mm-hmm. that's how we critique, you know, any innovations or any drugs that come in. So I guess from that perspective, we have that upper hand, and hopefully, if other clinicians are getting involved in innovation, that's listening, listening, you know, that's what I would see as a main criteria for them to do, you know, with whatever innovation they're working on.
Okay.
And I also think where we're going to go, and hopefully, where we definitely need to go is an evidence-based and outcomes-based payment results, payment methodology.
Yep.
Yeah. So, I mean, I don't want to be paid for Medic Bleep if I'm not helping the NHS pay back for it, if that makes sense. You know, I don't want to be taking from the NHS if it can't sustain itself. And if what I've implemented isn't helping transform it in such a way where it can release enough cash to pay. So I think those are the kind of models that are going to have to go in, you know. So we do essentially a benefit realized model for payment.
Okay.
So if we believe that with a trust, and we work this up with the organization, CCG or trust together, and we say, look, what processes can we help you redesign around this technology? The technology is only 10 to 15% of it, if I'm honest, Hassan. You know, the rest of it's a people thing, it's a change, it's transformation,
change, isn't it? Yeah.
It's culture, it's all of that, right? The tech is just a simple, easy enabler to it all, yeah. But actually implementing it and actually releasing that time or the efficiency or the cash, that's the tough part.
Yeah, definitely. So I guess hearing about that then, for our listeners, could you actually explain to us what Medic Bleep is and what exactly it does? Yeah,
sure. So I guess the easiest way to liken it is to WhatsApp, but for healthcare teams and organizations, right? So it's got a great directory in there, which makes it really, really easy to look for the person that you want to try and find. And in healthcare, what happens is we don't typically know who it is that we need, but we know what role they're in.
Okay.
Yeah, or roles they could be holding. And that's, you know, that's where we add value over a WhatsApp, along with also obviously all the governance and security.
It's interesting you mentioned that, because actually, if our listeners will remember a previous episode, we covered GDPR, and in that we talked about how you use communication methods and the fact that WhatsApp is definitely not GDPR secure and that kind of stuff, particularly for patient data. I'm guessing Medic Bleep sounds like you've solved that question, sorry.
Yeah, I mean, so you can solve that question a lot by technology, of course, but actually there's still a lot of it that relies on paperwork and working with organizations. So I can't just open up Medic Bleep, unfortunately, to all of your listeners without getting the appropriate documentations in place with them, or with their CCG or with their, you know, practice, if that makes sense. Because the easiest way to explain it is, if you're the patient, right, and you're downloading Babylon or a patient-facing product, Ada Health, in the T's and C's, you've given clear-cut consent for your data to be shared through those systems. Yeah.
Yeah.
And that's fine. Perfect. You've done that, knowing that that's what they're going to be doing, and you're the patient, so you've given that consent. Perfect. But now, let's say you're my patient walking into my practice. Let's say I'm a GP out in the community. So how have you consented to have your data shared in Medic Bleep or EMIS, or take any system really, system one, take any system. So that happens by the organization, so your CCG, or your practice having legal paperwork in place with Medic Bleep or EMIS to say, look, they're going to be handling your data with these criteria. They're not going to be selling onto pharma or to, they're not going to be abusing your patient data. And holding them to account. Should anything happen, let's say if their servers get hacked, that's how that relationship then works, because you as the patient have given that ownership and guardianship to the CCG or to the trust, and that's how it happens. So the trust needs to get into that formal legal framework.
And I guess that works obviously easier in the secondary care environment, because you work for the trust, and the patients you see are primarily through that trust itself. And I think you mentioned obviously you've seen a big proliferation of the service following Matt Hancock's trash the bleep, trash the pager kind of campaign and stuff. Yeah, well, it's been game changer. We were told in the same month, get rid of pagers, get rid of faxes and email, so don't use the post and stuff. So yeah, modern times. Can you actually see Medic Bleep being effective in primary care? And I guess a key vehicle for that I'd be thinking about is obviously PCNs.
Yeah, absolutely. So I mean, having seen healthcare from many different angles, right? So, and also in different healthcare systems. So having operationally run nursing homes and seen the revolving door syndrome, where our residents, inappropriately go back, or the carers refer them back into hospitals, or indeed send them into the GP, or actually call out a GP inappropriately, and how much time that wastes in the system is actually one of the biggest pain points why I started on this journey with Medic Bleep, right? So I 100% see it going across the whole SDP, and not only am I involving CCGs and primary care in that, I involve community, and I involve social care appropriately, of course, in that. Yeah. So we are working with some CCGs already, where we are looking at, well, how does this help your frailty processes, managing frail adults out in the community better, or your the tissue viability, the patients that need tissue viability nurses all the time, for managing their wounds better, right? So you've got your diabetics who've got ulcers on the feet, making sure that they don't get to the point of amputation, or that they're not inappropriately referred through to GPs or into the diabetologist or the vascular surgeon into the hospital. So those are the kind of pathways that we're looking at helping primary care with, or indeed the conversations between primary care and secondary care. How many times I had this a lot as a GP trainee, right, where I wanted to refer a patient, but I wasn't quite sure if this patient needs to go in to A&E or to AMU or to day surgery unit. And all I really wanted was a double check on the ECG and say, look, can I actually book them in for your do a 24-hour ECG on them and then get them into your clinic, or do I need to refer them with this ECG right now to you? But trying to get through switchboard and trying to connect with the med reg and call just took too much time. And all I ended up doing was then, here's the letter to the patient, and sent them in, because that was the safest thing to do at that point.
Okay. So it sounds like it works really well as a communication tool and particularly a integration tool, things like multidisciplinary teams and that kind of stuff. How does that integrate, I guess, with the how does
EMIS
that
and EHRs?
Yeah, so how does that integrate with, the EHRs, EMIS, System 1, that kind of stuff, and can it?
Yes, I mean, obviously, as a startup, we want to integrate. It to us actually, interoperability is critical path, and I mean, if there was one piece of advice that I could give to NHS Digital or NHS England, it would be, can you please just create the interoperability layers so that you're not having to, as a supplier, you're not having to talk to EMIS or talk to System 1 or other providers, but there's conflicts because maybe they don't want to integrate with you. But we do have the CCGs that we're working with. They are System 1, and so we are in conversation at the moment with System 1 to integrate. But all we want to do is very simple, which is pull from the PAS and then do a pushback of the conversation so that there aren't double entries. There should always be one version of the truth, and no more than that. And that's critical to make sure that this fits around the GP workflow.
Okay, and with all that kind of change happening and stuff, where do you see the future of Medic Bleep going?
Gosh, for me, I mean, if you could do some blue sky thinking on where this could go, it's imagine you wearing a Samsung Gear watch as a GP, or let's say it's on your table, or indeed you've got Amazon Alexa in your practice in your room, and it's transcribing for you through the conversational assistant or AI through Medic Bleep, and it can pick up, well, this is the patient speaking, or indeed the GP might say, hey, Hippocrates, which is our conversational AI that we're working on at the moment to be part of Medic Bleep, listen up, and that trigger, then the conversational AI understands that actually it's meant to be listening for the patient here. And so it's doing that transcribing for the clinician, for example. Or indeed, you could say, hey, Hippocrates, can you refer Mrs. Jones to the gastroenterologist in Addenbrooke's Hospital, please? And it can do that for you. That's where we're trying to take Medic Bleep. Okay.
That sounds really interesting, actually, and particularly the whole voice assistant. I mean, I love the name Hippocrates. First of all, that's quite cool.
Oh, thank you.
Right. So, I guess other questions I like to ask people, just because, as you probably know, and as our listeners know, I'm a bit of a geek when it comes to these kind of things. You're obviously working at the moment. What is your favorite kind of work-based app?
My favorite work-based app. Probably Streak. I like Streak's app, which is most people probably won't know it, but it's a CRM system like HubSpot or Salesforce, I guess. It's a great way to channel all of our relationships that we've been building over the last 4 years in, and it's I open that app probably 15-20 times a day at least.
Okay. I must admit that's not one I've heard of before, so I might have to go have a look into that.
Sure.
And I guess the other side of it, we all like to have our own downtime and that kind of stuff. So what would be your favorite non-work app, the app that you dial into straight away when you've got a free minute and thing?
Yeah, I mean, if I want to switch off, and it's really hard to switch off as an entrepreneur, if I just want nothing in my head, then I will probably switch on to Football Manager.
Okay.
Yeah, and try and win a few games on Football Manager and make sure I can buy the best players.
So I guess that means you see yourself as the next Sol Gunnarsson then?
Yes, possibly.
Cool. And another question I like to ask everyone that comes and joins us on the podcast and stuff is, imagine tomorrow you get a meeting with Matt Hancock, and he says to you, Sandeep, you know what, we need to change things. I'm going to give you £100 million, and I'm going to clear all the red tape that you don't have to worry about any of the bureaucracy. The only thing is you have to spend this on health technology. What would you do with it?
Well, I need to give him something realistic that he can do with 100 million.
Mm-hmm.
Can I be a bit clever about it? And what I would do is...
This is your money. You can do what you want.
It's my money. Good. So I would go to some philanthropic investors and leverage that 100 million to hopefully make it 500 million.
Okay.
And then put in that 500 million as core infrastructure 2.0 for the NHS. What I mean by that is upgrading it, making it sure that there's robust Wi-Fi, not just patient-facing, but for the clinicians, the networking, the operating systems are what we need them to be. You know, all of the daily stuff, logging in, 10 minutes to log into my GP, portals. I remember those days, and I'm sure they haven't really changed that much.
No, still.
Getting those basics spot on.
Yeah.
But allow that innovation. That we talk about AI all the time,
but
what is the point? What is the point till we can get those data points on the fly with APIs and have the infrastructure to enable that? We don't have that.
Wow. Okay. That is potentially game changing, and I can see why you're going to need to take that 100 million and make it a little bit more. Don't know if that's technically cheating with the question, but like I said, it's your money. Do with it what you want.
I'm an entrepreneur. I try to think out the box.
Yeah, no, that's great, and it's been great talking to you as well, Sandeep. I know our listeners would have got so much from this and stuff. And I guess my final question to you would be: some of our listeners will be obviously hearing this and thinking, either as a GP or a district nurse in the field, grassroots kind of thing, thinking, you know what, this is something I think that might help the way I work, my organisation, that kind of stuff, or it could be PCN lead or something else like that. How would they go about bringing a Medic Bleep to their kind of area to start using effectively to improve communication and stuff? What process would they have to go through?
Yeah, I think they would. What I've realised is, Medic Bleep on its own can't do much for them.
Yeah.
What you need is you need teams around you who are bought in. You need people at the top, right the way through to the bottom, who are bought into doing things differently, trying to change processes. And that takes time. So firstly, getting those other internal champions on board, so your CCIO, if there is one for the CCG, for example, or your chief nurse, or your board, essentially taking it to your board for the CCG, and understand that this is not just about communication. Actually, what you'll have to do is enable the infrastructure 2.0 and have the appetite to do that first, because I can't risk a message not getting through to the right person at the right time.
Sure.
And if that's a risk, then I'm not willing to go live and for patient safety with Medic Bleep, right? And that requires a lot of buy-in from key stakeholders on the shop floor. But if they can start to look at, well, how would their processes change? Where in their process pathways would this make a difference? And if they can start to flag those kind of things to the right people, in the weekly practice meeting, for example, I remember I used to be in those. I'm sure you do them as well. Flagging them, well, actually, this sort of communication method would make my life easier by this.
Okay.
That starts to build pressure on the CCG and on the right people. And that's when then we can come in and show them the art of the possible.
Wow.
But it's sadly not one that, that they can just go out and,
Sure.
download the app and unfortunately use by themselves.
So I guess if they wanted to find out more, where would people need to go to get more information? Would they contact you? Would you suggest they go somewhere else?
Yeah, go onto the Medic Bleep website, of course. That's got our peer review article on it. It's got some news bites on it. But then happily, of course, reach out to me. You've got my email address, so I'm more than happy to talk to people about this, and happy to fire off more information to them.
Sure. So that was Sandeep at mediccreation.com.
Medic Creations with an S. Sorry.
Mediccreations.com. Yep. Great. No
Indeed.
problem.
Yeah.
Cool. And for our listeners, all those links and stuff, we'll put those in the show notes. So if you want to have a look at those, feel free. And as we said, if you want to get in contact with Sandeep, email address will be there as well. I'd like to thank you for your time, Sandeep. It's been a great conversation. I know I've definitely learned some things listening to that, and I hope our listeners have as well. And you've also given me some ideas about how to move things forward as well, which I'm going to have to go off and think about, and definitely come back to you with some potential ways forward for that, really. It's been a great talk, and we may see you as the next manager of Manchester United as well. So I'm going to send you off as well, by the sounds of it.
Hopefully Arsenal, not Man U.
Fair enough. Okay. One side or the other.
Yes. Thanks for saying that. Really good talking to you.
Thank you for joining us, and enjoy your day.
Thanks. You too.
So, GP learners, I hope you enjoyed that interview with Dr. Sandeep Bansal of Medic Creations. In particular, I'd be interested to know your feedback, whether or not you think this is something that you would consider using in your area, or alternatively, if you're already using it, what is the benefits that you have found from using something like Medic Bleep in terms of patient care? If you want to leave specific feedback, contact myself at drgandalf52 or at EGP Learning. And if you're listening on the podcast, make sure you leave a review for us, because it really lets us know if we're doing good things for you on your platform of choice, whether that's iTunes, Spotify, Podbean, or Android. And if you are watching us on YouTube, definitely leave us a comment there as well. We promise to get back to you ASAP. We've got lots of really interesting interviews coming up for you in the next few months. And don't forget to check out our other platforms on Facebook at EGP Learning for some of the live streams that will be coming through shortly. As always, guys, subscribe, comment, share. Let's tech enhance your primary care and learning. See you later. Bye.